All right, the last talk, keeping us from drinking. Polygenic score in form models can improve screening for abdominal aortic aneurysms by Dr. Zhang and colleagues from University of Chicago and North Shore University Health.
Great, thank you. Hi, everyone. I'm David. I'm from the University of Chicago. Thank you to VESS for letting us present this data. So there is one disclosure. North Shore does have an agreement with two companies for developing genetic tests of polygenic risk score. So we'll start by some background about how we get to a polygenic risk score and what a polygenic risk score is. And it starts with something called a GWAS, which is a genome-wide association study. And essentially, that's a large case-control trial where researchers genotype hundreds of thousands, millions of patients. And what they look for is single nucleotide polymorphisms, SNPs, or these base pair variations that patients with a particular disease of interest have, where the control group might not necessarily have it as much. And so we looked at two particular polygenic risk scores, one for AAA, which had over 900,000 variants, and one for CAD, which we considered because it's like as a pan-atherosclerotic risk factor for developing AAA. And there are almost 2.5 million variants for that one in particular. And if you have this information, you can really go one of two ways. One way is to try to understand mechanistically how this particular SNP is involved in the disease process. And this is how PCSK9 inhibitors were partially developed, understanding how mutations were involved in cholesterol metabolism. Another way, and what we'll talk about today, is understanding how we can take these polygenic risk scores and perform individualized risk assessment, really to bring precision medicine to vascular surgery. And so we'll talk about this in two parts. The first is understanding just the polygenic risk score for AAA and CAD and validating it in what's called the UKB, or the United Kingdom Biobank. Oh, wow. That's a very large cohort of patients, or folks from the United Kingdom that were genotyped, and we'll talk about how PGS does in that, predicting AAA. And the second part, we'll try to understand how we can apply clinical and demographic information in combination with this genetic data to build a model that we call probability AAA PGS, and really understand how we can use this in the clinic and in our practice. And so you have here the incidence of AAA on the vertical axis here, and increasing decile as you move from left to right of PGS AAA, which is to say that folks on the far left in the first decile have the least number of mutations that are associated with AAA. And as you move to the far right, you pick up more and more of these. And what we find is that the incidence of AAA, all AAA, is 0.3% in the lowest decile, pretty low. We also looked at severe AAA, which we defined as patients who presented with rupture or who needed a surgery. And that's less than 0.1%, so still quite low. But as you move all the way into the highest decile, you see this like threefold jump in the incidence of AAA. And certainly I think this is strongly suggestive that, for sure, genetics isn't the whole thing, right? You're not going to get a AAA just because of a certain one base pair mutation. But there is a trend that as you pick up more and more of these deleterious mutations, your risk is going to increase, and your risk of having a severe AAA is going to increase as well. And so if we take a look at this in a regression model, you can see that traditional risk factors like being a man, being older, smoking cigarettes, those are all going to naturally increase your risk, which we all know. And then we found that if you have a PGS AAA that's high risk, which we defined as a score twice the mean for the cohort, that's also going to pretty substantially increase your risk with a hazard ratio of 2, which is almost approaching what the hazard ratio of smoking is. And we found that PGS-CAD, as kind of an atherosclerotic risk factor, also has an independently predictive hazard ratio. And so with this information, we thought, well, how can we apply this? How do we integrate this data with what we already know about our patients and what we know puts them at increased risk for developing a AAA? And so we combined a number of these clinical variables in addition with the genetic risk score to try to understand how we can take it all together. And you find that probability AAA PGS here down the bottom right, bottom left, with a high risk categorization, has a hazard ratio of around 2. Similar to what we showed with just the PGS AAA, but in our data analysis, we found that it captured almost twice as many patients as using just the polygenic risk score alone, which makes sense because you're incorporating other data, other risk factors. And you can see that smoking, being a man, being older, are still independently predictive for sure. And so what's one way we could use this information? One possible way is to understand how we screen patients for AAA and how we can improve how we do that. And so currently in the USPSTF guidelines, we look at men who are older who smoke. And in this particular cohort, about 6%, 5.7% of the patients fell into this category and would have qualified for screening. And amongst them, 3.2% of them ultimately developed a AAA. And so we thought about, what about everyone else? How do we adequately screen these patients? And so in this top row here, you can see all the remaining folks who are men. And we found that if we use a cutoff of 0.022, that's about 9,000 patients in this cohort, 2%. So a third of what we originally captured. But the incidence in this particular cohort is 3.2%, the incidence of AAA. So you have all of these men who would otherwise not qualify for screening, who are in a group with an incidence of AAA comparable to what we're currently screening. And something else that's really interesting that we see is if we look at patients who have kind of the perfect storm. So they're old, they're men, they're smoking, and they have high-risk genetic features. You see that the incidence of AAA in this particular cohort, which is a quarter of the overall cohort, is almost 8%. That's more than 2 times what their baseline cohort would have been if they didn't also have high-risk genetic features. And the incidence of severe AAA, so folks who actually needed the surgery or who presented as a rupture, almost tripled in their incidence to 3%. I think something else that we could try to address with this kind of data is understanding how we screen women, which is truly, one of the disparities in vascular care, is understanding how we address women in with vascular disease, and in particular aortic disease in women. And so we found that in our cohort, if we take a look at a cutoff of 0.014, it's 0.25% of the overall cohort, but it has an incidence of AAA that's comparable, again, to the men that currently qualify for screening. So, that this part of the model is not fully fleshed out for sure, and I think certainly, combinations with understanding other risk factors that women may have is necessary. But it goes to show that there's certainly a population of women that we can detect using genetics, genomic analysis, and potentially refer them for screening. And so another way we can try to understand this is, what about patients who may already, be in front of you here, and you're trying to have a conversation about, okay, you're high risk potentially, what can we do about that? And to start, we take a look first at patients who are low risk and non-smokers. You can see that the incidence of AAA in this cohort is pretty low, well less than 0.5%. But then if you add in smoking, you can see that the incidence of AAA naturally goes up, which is not surprising. And then if we look at patients who are high risk, who are non-smokers, you can see that the incidence, higher than your baseline, but lower than if you were just smoking. And I think where the real interesting patients lie is right here, patients who are high risk and who are smoking. So patients here have an incidence of AAA that's well beyond everyone else. And I think it goes to show that there's a potentially synergistic effect that's occurring between patients with genetic risk factors for developing AAA and patients who have modifiable lifestyle factors, which are also contributing to their disease. And so this is potentially another way you could use this data. If you've got a person in front of you who smokes, you find out they're genetically high risk, all the more reason to potentially stop smoking. And to wrap up here, I think the most compelling slide, hopefully I can show, is this screenshot out of Epic. And what it shows is that this is not the future, this is now. This is something that we currently are trying to implement at North Shore Health System, and we've developed a genetic panel that looks holistically at a couple of different cardiovascular diseases, CAD, AAA, AFib, and diabetes. And it's a quick mouth swab that a patient can do, and it provides you a huge amount of potential information about a patient's genetic risk factors, how you counsel this patient, how you might screen, how you might take care of them in the future. So with that, thank you so much.
Hi, Frank Davis, University of Michigan. Really enjoyed your talk. The application of polygenic risk score to aneurysm severity and/or aneurysm risk. I think that as AI and genetics become more available to us clinically, I think this is going to play a role. And especially your last slide with incorporating that in, I think is important. I guess my question for you, though, is as kind of a healthcare conscientious and cost. Are you guys doing that on all your aneurysm patients and offering this? Is it insurance reimbursed? And because I think the polygenic risk score from the UK Biobank is great, but clinically applying that is sometimes difficult and complex.
Yeah, absolutely. And I think that's a great point, right? How do we actually put this into practice? And so it's not currently covered by insurance, but it's relatively affordable as far as medical testing goes. I think it's something like $100 to $200 for a test. It's something that we're practicing as part of kind of the health system's initiative to apply this to all of its patients in a way. So I think lumping it on like that's the great thing with these tests. You can lump a bunch of these tests onto one, chip, and when you sequence, you can check for, a couple diseases at the same time to try to make it a little bit more affordable. I think the next natural step is trying to understand, okay, well, you have someone that you know is high risk, but Medicare is not going to pay for their ultrasound. I think it's trying to understand how we have to show that we're detecting people with AAA. We have some preliminary data for that. That's very exciting. That we'll hopefully get to share in the future. But I think as we show more of that, then perhaps we can move the needle on, incorporating this as a way we can get insurance companies to pay for screening.
And then as a follow-up question, it'd be very interesting in those patients who have aneurysm but are below threshold for repair. If they do get the genetic testing and are high risk, what is the growth rate on those? And as you follow those along, that would be a good stratification cohort for you too.
Yeah, absolutely. No, exactly. And so we also looked at, in the regression model I showed, we were just looking to detect AAA. We did also look at the ability of these scores to detect severe AAA. It's, statistically I think it's not powered to get there because the numbers were not so high in the UK Biobank. But certainly the trend is that if you pick up more of these genetic risk factors, your risk of having a severe AAA is going to go up. And then what do you do with them? What do you treat the small ones that are high risk? That's a whole other set of questions.
Great presentation. Thank you.
Thank you.
Hi, Dawn Coleman, Duke Vascular. Love that presentation. Thanks for bringing it to the meeting. I think it's a really nice starting point from which I hope you do a lot with. I'd echo all of Dr. Davis's sentiments and just ask you two more questions if you don't mind expanding. The first really is around what it took to execute the work that you've accomplished to date. And I ask you, acknowledging your practice setting and knowing that this took a village probably to implement. My second, and so comment maybe on accelerators or where you found barriers that you were able to mitigate, because I think it's important for the future translational surgeon scientists in the room. I think Dr. Davis gave you some comments to think about for your next steps, and so I'm anxious to hear what that looks like. But my other really important question is around this concept of genetic sequencing. This is different, obviously, than whole exome or GWAS analyses, but there is a genetic consideration with data that you're already building into your practice models that will translate potentially into a clinical practice change. And so as you acquire this data and you think about returning results and the counseling that you referenced in that slide, that's an important consideration. What does that look like and who's doing it? In general, this assessment makes maybe more sense in a resource-limited genetic counseling environment where we struggle to get the consultations and the sequencing sometimes that we really are looking for, especially with some of our rare diseases. But I wonder if you've got some comments to that end. And I would highlight this precision health is a priority by many funding agencies right now. Look at vascular cures, and just thank you again for the work you're doing. I commend you and your co-authors.
Thanks, Dr. Coleman. To address your first question, yeah, absolutely. Dr. Lee and I are only a small part of this team. I think we've been fortunate that the enterprise, North Shore's enterprise, and has really invested a lot of energy into making this a part of the care that we provide. So we work with a group of genetics researchers who really drive a lot of this. But I think it's really that partnership that vascular surgeons have to be a part of it, right? Because from a geneticist perspective, AAA, it's a common disease, but it's like 10 in 100,000 compared to diabetes or CAD or some of the more prevalent diseases out there. But it's something that we can do something about as surgeons. And so I think that that's part of, you have to be a part of that conversation to sort of direct how these resources are being divided and being a part of those teams so that we're able to kind of advocate for our own patients. And then absolutely, I think the future is, for this is really kind of what we can, whatever we can dream of. I think in terms of actually implementing it, right now it's being rolled out in kind of the cardiology clinics and vascular surgery clinics. But I think your point is excellent that, genetic information is sort of a black box because you open it and then you maybe find things that you didn't want to know about all of a sudden. So I think having genetic counselors, folks who are more particularly, knowledgeable about how to approach patients, especially if you have an unexpected finding, is definitely a part of the solution.
I'm not going to say much. Dave did a fantastic presentation for us, but I appreciate your interest in this. And to answer Don's question, it's really up to us. We physicians, especially the surgeons, have to be the champions for taking this tool, utilizing it. And at the time, we're doing some real-time validation within our own system's genome bank. And we have some really exciting results. And next is this. I'm trying to, it's about a $250 test. So it's not affordable, so to speak, but it's actually cheaper than an ultrasound, if you think about it. And piggybacking on with the other disease processes that we're trying to look at, which is namely cardiovascular disease, heart disease. So, I think we're going to get a lot of information that's going to be valuable in that setting and more applicable, not just specific to AAA, but other peripheral diseases down the line. Thanks.
Is there a way, as you monetize this, to get the cost down? Because, as you know, there's a big push now, especially I guess people of means, to go to concierge medicine. And part of the concierge medicine is the whole idea of preventative medicine, right? The medicine 3.0. And so in that way, they're going to pay for things like genetic testing that insurance may not pay for. And so if you can get this price point to $50 or $100, there may be a whole lot of people that are willing to pay out of pocket and not require insurance to cover some of these things that really need to. And you might even be able to have a program in your own institution where, all right, we think this patient needs genetic testing, insurance isn't going to cover it, but, Medtronic might, or Gore might, right? Because it's in their best interest to identify people that have aneurysms and need to be fixed, right? And so maybe there's a way to collaborate that doesn't require to go out of pocket. And so that's the first question, or comment, I guess. And the second one is not all ultrasounds are as expensive as you think, because you can still do lifeline screening for $100. And so really part of it depends on how much the patients are willing to, put out of pocket to promote their own health versus relying on the government to pay for everything.
Yeah, sometimes it's just a practicality.
Sure.
You're right there with a swab. In clinic, you're seeing the patient, hey, are you interested? We swab them. Instead of coordinating the procedural list for the ultrasound or the time, sort of it eliminates that factor. But it's funny that you asked that, because we did propose it to Medtronic last year.
Oh, I just threw them out.
We didn't get the funding, but we did have private funding for this, and that is the price. The price point that we got down so far with this company called Genome MD was $250. But if we have more funding, more support for this, absolutely, we're going to get it cheaper. And we're trying to apply for grants right now to have this free, so that we could actually do some, more applicable validation in the real world with patients that, without cost. So.
Well, and as you identify more targets, maybe there is a way to come up with a vascular, test where you would be able to not only identify aneurysms, but who knows, carotid disease or whatever, future risk of diabetes, whatever you want to do. And so you could bundle it together for people in their 30s and 40s to tell them to stop smoking. Okay.
Absolutely.
One more question?
Hi, Ian Chesser from the UK. Really interesting, actually. What I would be really interested in is, in a patient who's got an aneurysm, a small aneurysm, can you use this to predict whether that aneurysm is going to expand or not?
Yeah, no, absolutely. I think that it's definitely one of the things that we want to look at. We did look at whether or not it predicts patients coming in with a rupture or needing surgery. So, presumably patients with an aneurysm, greater than the current cutoff. It was underpowered to answer that particular question. I think if we especially are able to get this kind of data on a cohort of patients with AAA, then you could really have some really nuanced analysis of understanding all right, amongst the people with a AAA, does someone with a 5.5 centimeter aneurysm versus someone that's at 7 centimeters or who grew a centimeter in a year, were there genetic differences between these two populations? So I think as we get more people enrolled and tested, that kind of data will come out.
All right, thank you.
Thank you.